Okay, so good afternoon and welcome everybody. This is the highlights and best of BAUS session. So it's the penultimate session of the week. I think it's been an absolutely fantastic BAUS 2019. There have been amazing things going on throughout the whole conference, and I really think that one of the things that we've done very well this year is just the extracurricular topics we've covered. We've covered innovation, we've covered burnout, we've covered academic publishing. There's been some really strong BAUS section of trainees sessions that have been absolutely excellent. We've had fantastic guest speakers, and in this auditorium itself there have been some great things going on, including a universally challenged, or university challenged as they call it, university challenge. We've had Il Divo on this stage on Monday night, which you have to be a certain age and gender to know who they are, but world famous singers. Not part of BAUS, but I'm glad I'm sharing the stage. They were standing right here. And we're going to carry on today's session with highlights of the separate sections of andrology, oncology, female and stones, and endourology. So I'm very pleased to introduce all our speakers. If I can have the first slide. So we've got Mr. Will Finch, who's going to talk to us about endourology, and I'll invite him to the stage in a moment. He's a consultant at Norfolk and Norwich Hospital, and he specialises in stones, HOLEP and upper tract laparoscopy. Followed by Mr. Krishna Narahari, who's an oncologist. He's currently working in the University Hospital of Wales in Cardiff, who specialises in prostate, kidney cancer treatment, including robotic surgery, and is the current secretary of the BAUS section of oncology. And Ms. Ayo Kalijayi, who is our andrologist today. She works in University Hospitals Birmingham, and she specialises in andrology, infertility, and uro-oncology. So if I can kindly ask Will to come to the stage, and we'll start with endourology highlights and the best of BAUS. Thank you.
So, good afternoon, everybody. I'm going to take you on a gallop for the next 15 minutes through endourology over the last 12 months. And a big thank you to everyone from the section of endourology for putting together what's been a great program. And we'll touch on the second half of my talk on some of the highlights as I've seen it and the take-home messages from those endo sessions. So in terms of the world literature for the last 12 months, it's quite daunting to look at it. And Professor Neal's talk yesterday I particularly liked when he told me there was 168 indexed urology journals. And I can promise you I haven't looked at all of those. But here is my highlights of stones and BPH. This is a study which we talked about at the RSM meeting earlier in the year. This is Andy Portis, and it's a study which published in the BJUI this year where he looked at the world of passing stones post-tamsulosin. And the take-home messages here for me are that with patients, with excellent information, telling them what they're going to be doing, excellent analgesia, and optimizing the process and the pathways and who to contact and their follow-up around them. In the States, they encourage more people to pass their stones, but more importantly, in those people passing their stones, the intervention rate for surgery dropped from 26% down to 20%. And overall, they noticed a significant reduction in surgical intervention with supported stone passage. So the take-home messages for us is that I think we can do probably better with our patients who are on medical management of stones. We don't use tamsulosin, but we can work really hard on patient information and supporting these patients and giving them the best chance of passing stones. So those with renal stones, the asymptomatic renal stone, something that we all see in our clinics on a weekly basis. This large study from China looks at 10 years of retrospective data with a mean follow-up of just shy of 5 years. But what it gives us is contemporary, up-to-date information on what happens with people who we're watching renal stones. It gives us some up-to-date data on the likelihood of them passing that stone at about a third of people, stone growth in about 16%, developing stone symptoms in a further third. But interestingly, a low requirement for intervention at 12%. In their multivariate analysis, they go on to look at reasons why stones may grow, and in groups of people that's more likely. But some really up-to-date data that we can use in our clinic next week with this group of patients. The negative ureteroscopy, we've talked about that here over the last few days, and some units are very lucky to be able to have on-the-day imaging or imaging in the few days before surgery, but it's certainly not widespread practice. This study, published in J-Endo-Urol last year, looks at clinical parameters in which our index of suspicion should be elevated for people who are likely to have a negative ureteroscopy. It's really important that we know our negative ureteroscopy rate. In this paper, it's 3.8%. And they suggest that in women, the negative ureteroscopy rate is higher. In stones you can't see on plain film X-ray, and also small stones. This is the group of the people that perhaps those of us who don't have on-the-day imaging should be pushing to get imaging to reduce and minimize your negative ureteroscopy rate. We've done a lot of work in the section with our registry looking at infection, and this is another Chinese study trying to identify and predict who's going to have a post-op septic complication after PCNL. A nice study with a post-operative sepsis rate which fits with our experience in the UK and our registry data. They've identified from multivariate analysis some independent risk factors, and the real take-home message for me is the operating time, and operating over 100 minutes is significantly associated with the likelihood of a septic outcome, and that's a real take-home message from this paper. We've had discussions about the role of urine dipsticks and predicting infection, and I think the operative group are different to the group being looked at by NHS England at the moment. But positive urine dipsticks, likelihood of a septic complication, positive urine cultures, positive stone cultures, all associated with an infective complication afterwards. So the take-home message: we need to identify these patients with positive urine dipsticks, make sure we're absolutely happy that we've treated and minimized their risk of infection before we operate on them. So moving on to outcomes from surgery, there's been a theme at this meeting, and there's a theme in the literature that our traditional approach with plain film X-ray underestimates really the amount of stone left after an operation. And there's a drive to image people with CT, and this nice study from urology has a sort of contemporary series to what we see in UK practice with an average stone size of 6 mil. They use a lot more access sheaths than perhaps we do in the UK, but a mixture of dusting and basketing. And a CT at 3 months follow-up shows a 0 fragment stone-free rate, so absolutely stone-free in 73% of people. And I think this is really interesting because it's data that we should perhaps be quoting now and looking to see how our data, and being honest about what follow-up methods for imaging we should be really using now that we know about a bit more about radiation doses and the role of those in follow-up. So outcomes from PCNL: if you do your PCNL, visually you look around the kidney, you use fluoroscopy, and you're happy it's stone-free. But is that really stone-free? This study asked surgeons to classify at the end of the procedure, was the case stone-free or insignificant residual stones less than 4 mil, or was there significant stone burden? And in cases where the surgeon felt that he got them stone-free or near as he could do, there was still nearly 20% of cases had significant stone burden. More likely to be a problem in the multiple stone patient or in stones with or the larger stone burden. But I think this is interesting, and the take-home message for me here is that we need to think about these multiple stone patients with large stone burden and perhaps imaging them sooner so that we can then plan adjuvant strategies to get them stone-free. Once we've operated on people and got them stone-free, who's going to require surgery in the future? And this is a paper in press in the BJUI, which looks at a group of people who've had stone surgery with nearly 5 years of follow-up. Yes, 60% of people have had stones before, but what they looked at was people who formed new stones in the same kidney or new stones in the contralateral kidney, and that happened in 25% of people over a 5-year period. So nice data, contemporary data, which we can use to educate our patients about the risk of stone recurrence in the future. They've identified reasons for people having repeat surgery, whether it be pain, stone size, infections, blood in the urine, or asymptomatic obstruction. And they've also, through multivariate analysis, identified in people or risks which increase people's risk of surgical recurrence. All of those, interestingly, have the same weight attached to them, and they've moved on to suggest that you can sort of risk stratify these people into low, intermediate, or high risk of stone recurrence. And this, I think, sort of sets us on a journey whereby we should be looking to risk stratify our patients for future stone events, which may then allow us to risk stratify their follow-up or investigations or further metabolic treatments potentially. And my final stone slide from the literature, we've heard a lot in recent times about the debate of single-use and reusable flexible ureteroscopes and whether they work, whether they're equivalent, and when to use them. This paper tells us about infundibulopelvic angle, and the narrow infundibulopelvic angle is important. Their breakage rate in this series was about 10% for their reusable scopes. But a narrow infundibulopelvic angle predicts flexible ureteroscope damage, it predicts Clavian Dindo 2+ complications, and it predicts prolonged hospital stay. And so for me, perhaps we ought to be looking from our pre-op planning CT for this angle, and if the angle is less than 55 degrees, it perhaps guides us, for those of us who do have single-use scopes, to use a single-use scope to protect my reusable scope, but also hopefully avoid complications and avoid a prolonged hospital stay. So BPH. The theme I got looking at medication-related papers is that we're all very comfortable using tamsulosin and 5-alpha reductase inhibitors, which I'll talk about shortly. But there's been some literature reviews and some editorials in the American literature suggesting that now these patients of ours have been on these medications for a long time. Actually, there are some slightly worrying side effects beginning to be noted. So admittedly, these are cohort studies, and that all has limitations. But in this paper, they suggest that tamsulosin may be associated with a higher risk of dementia. And in this paper, looking at dutasteride therapy, again, a registry retrospective study, but potentially associated with diabetic changes, liver function changes, cholesterol changes, as well as testosterone and ED changes that we're all well aware of. But for me, this changes the conversation that we perhaps should be having with patients about moving away from that traditional medication and then surgical approach to BPH and having that conversation with the advent of minimally invasive therapies much earlier, especially with this knowledge that perhaps there are some side effects that we haven't previously been aware of. There's a number of minimally invasive BPH techniques. Urolift and the Cochrane review of Cochrane collaboration have looked at this and reported on this recently. Resume, we've seen this data presented here earlier in the week, showing 50% near improvement in IPSS, quality of life, and flow with a low surgical retreatment rate at 4 years. Aquablation. This paper from the BJUI this year in Press looks at large prostates, which shows that they do have improvement in IPSS and flow, but again, there continues to be a high intervention rate for hematuria and complications associated with it. But a nice study in patients with large prostates, which is important and relevant to everyday practice. We've seen this study presented earlier, was part of this study presented earlier in a poster session, and the UK registry of prostatic artery embolization reported last year in the BJU, and again they've shown improvement in IPSS, not as much as TURP, and a reoperation rate and some complication data associated, but an option, and a minimally invasive option for men, and something certainly to discuss. I'm an advocate as HOLEP, as you've heard, and this paper caught my eye in JU Roll this year, a large number of patients who've been followed up for the longest follow-up, 18 years, but now 10-year data showing that men continue to be pleased with their flow, pleased with their symptom scores, and with a low complication rate from surgery out at nearly 10-year follow-up. And for me, that's very reassuring for HOLEP and durable long-term outcomes. So that's the literature. And moving on to the meeting, I think it's been a fantastic meeting. There's a lot of hard work and effort from a lot of people go into getting the endourology program together. And for me, there's been a real theme of quality improvement and some novel research. And in the first poster session, this study by Ben Turney and his group in Oxford, looking at their biobank of stone formers and collaborating with a group in Japan. And they did a huge GWAS study on these well over 400,000 patients and identified 10 novel genetic foci associated with stone disease. And this is really exciting and the first step in potentially a journey whereby people can have a personal risk alleles identified for stone disease. And if these risk alleles have got pharmacological or interventions for them, we can potentially in the future pick the reason that people have stone disease and intervene and reduce that risk for them. This study from Salisbury looks at the dose that we're giving our patients with plain film X-ray and CT. And whilst it did generate some controversy about the effective dose associated with a plain film, it makes the point that we need to know how much radiation we're exposing our patients to. For patients of my size, it appears that we're getting a higher effective dose in this study with plain film than CT, and therefore perhaps we ought to be using CT more in that group of patients to minimize the radiation risk and also optimize and make sure we know what the stone burden is we're dealing with. This study looks at stents. It's a study that's been performed in Cambridge with Ollie Wiseman and Olivier Traxé, and is a randomized control trial looking at a silicon stent from Coloplast and comparing it with a standard stent from Boston Scientific, the Perculaflex Plus. They show that using a validated symptom score, the USSQ, at day 20, there's significantly less pain with a silicon stent. They also show that there's significantly less encrustation with a silicon stent. And the take-home message here for me is that silicon stents appear to have advantages for the patient for medium and long-term stenting. Any patient having a stent less than 20 days, we're not going to see that advantage, but a nice study with a clear message. We're very lucky to have Professor Kershigani over from Michigan, and he gave us a really fascinating talk. The first half of it concentrating on laser energy and the effects of that energy on a stone, and giving us a real in-depth understanding of how we should be using our settings to achieve various stone ablation fragmentation techniques. And for me, the real take-home message was that, manipulating and changing your laser settings as the stone characteristics and size and composition of your fragments change throughout the procedure. And your laser settings are a very dynamic thing during a procedure. And the second half of his talk focused on quality improvement and explaining that the emergency department visit rate really is an emerging quality indicator for ureteroscopy and colic pathways. And he showed us areas of good practice and quality improvement that they'd used to improve that process. As part of that, in the UK, we have the BURST Collaborative, and Nikita Bhatt, who's a trainee in East Anglia, in the Dragon's Den BURST session last year, had a nice project about identifying how long we should be leaving stents in our post-ureteroscopy patients. And it's really nice to see how that's progressed, and that study has a number of different platforms ready to go with it. And I would encourage you to fill in the survey on the BAUS app from the Monday afternoon session to look at the take-up and help contribute to that, so that BURST can move forward with what's potentially a really exciting stone study to be done in the UK. So just finishing up, we had a very nice session on the Nice Stone guidelines yesterday. And the take-home message for me really was that if we're going to try and achieve stone treatment for ureteric stones within 48 hours of presentation, for the vast majority of the UK, that requires significant service reconfiguration. And to achieve that, there's been some quality improvement projects presented over the last couple of days. And this looks at the effects of networking and units coming together and a small DGH joining forces with their stone pathways with a large teaching centre. And it shows that with collaboration and working together, it's produced a reduction in treatment time for that small DGH by nearly 30 days, and also a reduction in the actual number of patients requiring treatment. So working together, sharing pathways has had a positive effect on the patient journey and the service that they're offering. Lithotripsy is what we should be aspiring to according to the NICE guidance for small ureteric stones, or stones less than 10 mil, should I say. But that's not on offer to everybody. But what is on offer to most people is the ability to do ureteroscopy, albeit not in an emergency setting. And this study from the Wirral by James Glendenning's group shows that actually if you do concentrate and look at your processes, that primary ureteroscopy can be delivered in 3/4 of the time on the same day in collaboration with your middle grades in a safe environment with a low complication rate. And then finally, my final slide is best poster from yesterday. It's got one of the most complicated graphs I've seen on it in a poster session before, but a really important, clear take-home message. In people who have ureteric obstruction, who we are intervening in, for the majority of people, we are not improving their renal function. We're merely stabilizing it or protecting it. And in Darren's group here from UCL with his colleagues, for those with malignant obstruction and for those with very poor renal function, that means a conversation about quality of life implications for stents and for nephrostomies and intervention if it's actually not going to improve poor renal function. But a very nice study and one that's got a clear take-home message. So thank you very much. It's been a fantastic BAUS. Thank you very much to everyone who's helped me put my slides together. The future is bright for endourology. There's a lot of hard work, a lot of exciting things online and coming online. So thank you very much.
Okay, thank you very much, Will. That's excellent. I think the take-home message, because this session is really to help people that aren't necessarily subspecialising in stones or any of these other aspects that we're talking about today to really keep up to date with things. And I think the take-home message is that this kind of information is going to help us know what our stone-free rates are after flexible ureteroscopy and after PCNL, and really counsel patients. And I think the idea of risk stratifying patients is excellent. And in my own practice, I'm going to have to think about using silicone stents for my reconstructive patients because they have stents in for more than 20 days sometimes. And also this push for primary ureteroscopy really is an emergency rather than always putting stents in for patients. I would like to invite questions, please. We've got 4 mics on the floor. Please don't be shy. This is your time to ask. And also, we do have the app as well. So if you want to use the app to submit questions, I'm happy to do that as well. Any questions? Yep. So mic 4, please. Sorry, I can't see who it is.
Sorry, it's not the... use the word middle grade. You're no longer supposed to use that word. It's SAS doctors. So
I apologise. A slip of tongue. It wasn't meant to be derogatory in any point, but those supporting that area of on-calls, and there's a variance in roles and what they're called across different organisations, they're incredibly important. And the real take-home message from that piece of work from the Wirral is actually engaging and supporting your team to help with delivering this care and supporting people to do support acute treatment for ureteric stones in a safe, supported environment with your team around you. So no offence was intended. Very, very, very important members of the team.
I think the only other comment I'd say is the HOLEP data at 18 years is very interesting. We're starting to see more bladder neck contractures and urethral strictures coming through from bladder outflow surgery, and HOLEP had been something I'd been noticing, but in fact a rate of 3.5% over an 18-year study is not too bad. It's pretty good.
So we've got a reasonable experience of HOLEP in Norwich, and it's always a concern, especially with the smaller prostates, but it's not something that we are seeing, and actually that data slightly sort of reassures me with that. But I think we need to follow our data for longer.
All right, thank you very much, Will. So I'd like to invite Krishna to the stage. He's going to give us an overview of oncology. I think things are getting very interesting. The role of immunotherapy for urothelial carcinoma is a very interesting development. I'm keen to hear about more about it. So Krishna, if you'd like to make a start.
Just checking. Thank you, Suzanne. So, my whole adult life, I've religiously and meticulously gone to a dentist every 6 or 12 months as advised, paid £20 or so as instructed, to be told that I have 32 teeth, which my 7-year-old can do just as well. However, on Monday evening, I found myself in that place with a very painful tooth. And then this, and this, and then this was offered to me for a dental abscess. So my sincere apologies. I have not been able to personally thank all the people who've presented, chaired various parts of the section presentations, and the audience who've come to the meetings to make it a success. Believe you me, I'd rather be with you in the evenings having that rather than settle for this. But such is life. So the talk is about highlights of BAUS 2019 and highlights of the year. It is daunting, as Will said. There's so much literature. And if one message I could take away is there's no p-values here, but there are p-values, as in Neil Spenceley's talk about the person value. Hopefully that's my ending note. So I'm going to break this down into highlights of the year and highlights of BAUS 2019. And I've just picked 3 things in the 3 main cancer areas which I think are relevant to British urology and have some futuristic value. So, prostate cancer. We have to talk about the NICE guidelines. I think PROMS, the NPCA PROMS and PREMS is excellent data, real-world data that we should talk about. And STAMPEDE, that is a game changer and will continue to be so. So, the NICE guidelines were published after a consultation in May of this year. And there are lots of changes, but the main ones being pre-biopsy, multi-parametric MRI, and MRI-influenced systematic biopsy, hypofractionated radiotherapy over 4 weeks as opposed to 7.5 weeks, which is already the standard of care in most places. Chemotherapy in metastatic prostate cancer upfront, but also considering it in high-risk non-metastatic prostate cancer, and ABI and ENZA in post-chemo setting. Second point, the National Prostate Cancer Audit, the PROMS and the PREMS. Now, this is the only national data set that focuses on PROMS and PREM outcomes in prostate cancer treatment, not surgery, treatment in the UK. For that reason, I think this is highly, highly valuable. And in the section of oncology meeting, we have the pleasure of having this as a breaking news session where Professor Clark and his team come along and give us the annual report. And we hope there will be one such report in the November meeting. So infographics are excellent. We know now that we are treating far less low-risk prostate cancer than we were before. We are treating more high-risk prostate cancer, as we should be, than before. And look at this, 90% of patients are generally happy with the care they've received. That's excellent to know, I think. And some real-world data on urinary continence or incontinence, potency, and bowel dysfunction. And I think this is important for us to be able to either show this to patients in the clinic or at least have an honest discussion to say 2 in 10 men after surgery will be wet requiring a pad. Does not necessarily mean they need a sphincter, but they will be wet requiring a pad. And that a majority of all comers, only 20% recover their potency. If you super select out the young, the fit, the low-risk disease or lowish risk disease, excellent nerve sparing, yes, you can get potency rates higher up. But in all comers, it's about 25%. I think it's important to reflect on this and be honest with our patients about this. And then there's, of course, STAMPEDE, which is a game changer. Now, this is the STAMPEDE M1RT data, which has clearly shown that in low metastatic burden or oligometastatic disease, however you choose to define it, less than 5 bone mets, less than 4 bone mets, no visceral mets, pelvic-only disease, etc., there is benefit to local treatment to the prostate with radiotherapy. And that has been also assessed in the meta-analysis, the stopgap meta-analysis, which agrees with the same result. And this has particular relevance to the surgical fraternity, because there may well be a role for a prostatectomy in oligometastatic prostate cancer. And we know the trombone in the UK, G-RAMP in Germany, and SIMCAP, so 3 randomized controlled trials trying to assess the role of prostatectomy in oligometastatic or low metastatic burden prostate cancer. I think in the next few years we will see this, because surgery offers the opportunity to know the cancer better at a molecular level and hopefully then treat the systemic disease better, potentially. As far as kidney cancer is concerned, in the world literature, there's a couple of interesting papers, presentations in AUA this year. We have to talk about Carmina, a bit like we have to talk about Kevin, and the IBS and the MABS, which is a minefield in itself. So I just picked out these 2 papers relevant to partial nephrectomy surgery. One was by the MSKCC group, and the other by the Canadian group, 6 centers in Canada, assessing in a randomized controlled fashion the benefits, or not, as the case may be, of renal hypothermia and mannitol in partial nephrectomies. Interestingly, in the hypothermia group, they included all patients, including people with poor renal function preoperatively, and found that there was no significant difference in long-term GFR. And similarly, in the mannitol group, there was no difference. So if any of us still carry on doing ice slush cooling or use mannitol pre-clamp, I think we have to think about it once the manuscripts of these become available for further scrutiny. Secondly, Carmina. So now this it has been a big paper, and there are lots of criticisms of it, but essentially the Carmina said there is no benefit or no role for cytoreductive nephrectomy in metastatic renal cancer. But we know that this has lots of deficits, and I'll just stop at this stage and come back to it again, if I may, because there's some very good local data presented in this meeting that proves this is not at all the case in the real world. The second point is the IBS and the MABS. I make no apology for this slide being busy. You could pretty much put an IB or a MAB to any word, and that is a drug for renal cancer. Now, a moment of reflection here is, should we as urologists be managing these patients with advanced disease? We've been at this juncture before with urogynecology and female urology, and the gynecologists ran away with that. Or with prostate cancer systemic treatment management, and the oncologists are running away and have run away with that. And I think we're again at that juncture. And it's really for us to think about, what do we want our trainees in the future to do? Do we want to be managing advanced disease, or do we want oncologists? Is it that this train has also left the station? It's something to reflect on, I think. As far as urothelial cancers are concerned, I just picked out 3 interesting areas. VIRATS was presented in the section meeting last year by Jim Cato and team. It's quite exciting. It's early, it's in development, but it could be the game changer in prostate cancer, in bladder cancer diagnostics, like MRI has been in prostate cancer. We don't know results for this yet. Like I say, this is in development, but this is very interesting stuff. POUT was presented here and in the ASCO and the ESOU meetings, and the take-home message from POUT really was that there is clearly a benefit, a survival benefit, for adjuvant chemotherapy in high-risk upper tract urothelial TCC, which I think is practice-changing. And finally, again, advanced bladder cancer treatments. Look at the number of trials assessing various agents in various combinations in advanced metastatic bladder cancer. What's most interesting about this is a lot of these trials are now also assessing this in high-risk, non-muscle invasive, non-metastatic bladder cancer that can't be treated with a cystectomy because the patient population is not fit. So until now, we've really had BCG or various versions of mitomycin or the epirubicin or certain other agents only for this group. where there are currently ongoing trials assessing the role of these agents in non-metastatic, high-risk, non-muscle invasive bladder cancer. And that, I think, will be a very interesting development for the future. So, moving on to BAUS highlights. Well, we talked about Carmina and its deficits. There were two excellent papers. The one on your left is the paper from Guy's, and the one on your right is the paper from Newcastle Group, David Thomas and Tim O'Brien's group, respectively. And showing that Carmina does not somehow reflect real-world urology nephrectomy practice. And I think we all know, even our own oncologists agree. And I think the take-home message with cytoreductive nephrectomies in the suitable patients with either low or intermediate metastatic burden, cytoreductive nephrectomy certainly has a role. Look at these survival results here, as opposed to the Carmina. So this is Tim's team with the Guy's cohort versus the Carmina cohort, and look at that survival benefit. So there clearly is a role. And I think, if anything, it actually proves that we are selecting out the right patients to be doing cytoreductive nephrectomies on. And I would urge you to enter your data to the BAUS snapshot audit that is currently ongoing, and we may have some further updates in the November meeting. So please do come to that. The other point I noted is the renal cancer session was meant to be renal cancer testis and sarcoma. We didn't have a single abstract in sarcoma or testis cancer. So there's a message to send out to our trainees, our departments, to say that's a good area to do projects on and submit to BAUS. So it'd be nice to see some local work in that area. Bladder cancer, we had two very good quality randomized trials, the Caliber and the Selenibit trial by Rick Bryan's group. Although the trials in itself are negative, there was some useful data to know. And then the Identify study. This is fascinating stuff. Look at that. Nearly 10,000 patients who presented with hematuria, non-visible and visible, and the incidence and prevalence of bladder cancer, upper tract cancer, prostate cancer in that group. And this is only possible because of the BAUS collaborative, and that is just mind-boggling stuff. There's no way without that international effort you would get these many patients into a trial, into a prospective sort of cohort study like this. So I think this is going to inform future practice without a doubt. In prostate cancer, I picked this out. There was a poster on whether or not anti-incontinence surgery should be centralized. But the key message for me from this was the time to anti-incontinence surgery post-radical prostatectomy is 3 years. That is very long to be wet and miserable. I'm a prostate cancer surgeon myself, and I think there's a lesson here for us to learn. If we make people wet as a result of surgery, which happens, we know there is an incidence of severe incontinence after radical prostatectomy, we need to fast-track them through with our reconstructive colleagues to get their quality of life back and to get their misery out of the way, if you like. And I think that is really crucial. That's a big, big take-home message for me. So the next time I find somebody who's quite wet for surgery, I'm going to knock on the door of my reconstructive colleague to say, look, this man's likely to need a sphincter. Can you please see him sooner? This is UK data based on HES. It is not a registry data. So I think it's quite important, and it certainly is a message for us to take. For Vincent Gnanapragassam's group presented two papers on the PREDICT prostate cancer tool, which is quite interesting and certainly useful in counseling people with low and low intermediate risk disease, even in high risk disease, by showing them certain tools. And I used this tool yesterday and the day before to showing them the risk of morbidity with surveillance versus radiotherapy versus surgery. So I'd encourage you to at least look at it, because you can use this in patients to visually show them what it is that they're likely to get as a side effect from treatment, which may then influence how they choose what treatment they eventually decide to have. We had an excellent trainee session, the BSOT session and the BURST session. We've talked about this before, and I think the power of this, if you look at the number of trials, the DETOR, the PROPEL, the IDENTIFY, the MIMIC, it's just fantastic. And then that was topped up by a very entertaining and thought-provoking, I think, and a candid talk by Adam Kay, which I thought was really, really fascinating and interesting. On Monday, there was an excellent session I went into, led again by Tim O'Brien, about clinical leadership. And I thought when I go in there, I'll see, mainly older folks and who are towards the end of their career. Quite the opposite. It was a mixture, and it's about more collaboration and networking. And I learned a lot from this, only as an observer. And I'd encourage you to come along to this in the future. Angie Smith from the USA gave us a great talk on sarcopenia and rehabilitation, and was ably assisted by Jagdeep Desi about assessment of the frail and the elderly, which was fantastic, I thought. This morning's lecture on innovation, the clinical entrepreneur program, and the chap, I think from Devon, who was talking about using watercress to treat nappy rash in children. And that's, again, this is mind-boggling stuff, but I thought was really, really good. I think this is what makes BAUS special. There is science, there's lots of Kaplan-Meier curves, there are lots of p-values, lots of hazard ratios, but to balance it out, there is real world, there's a person value here. And this is really, really good, I think. And we had an excellent session on advanced cancer from Professor Alex Motry, from Professor Dean Harris, Paul Cathcart, and Matt spoke very well about the Bill Turnbull effect. And talking of Bill Turnbull, his talk I thought was delightful. Very honest, but very, very entertaining in a way. The Atlantic Seamen, again, their talk was inspirational, and so was Adam Kay. I think to top it all, there was quite something insightful here. In our president's address, I learned that urologists have the highest rate of burnout. And Adam Kay made a very good point. He said, look after yourself and look after your colleagues. And I think we need to do that better, because for some reason we seem to have the highest burnout rate. Finally, to top it all, the highlights of BAUS Oncology for me has been that the best trainee in urology this year, Viru Kasi, the best trainer in Herman Fernando, the best young urologist, Ben Chalacombe, and the best senior urologist, Alex Motry, are all oncologists. Thank you.
Okay, thank you very much. So take-home messages again from me is making sure I'm up to date with the nice prostate cancer guidance. I've read half of it so far. I'm going to do it. Predict is doing excellent things, and I would encourage everybody to use that as a prostate tool to give your patients more counselling about their possible outcomes. And for next year, we need some testis, cancer and sarcoma abstracts, please. But my question, if I'm going to kick it off, and if anybody else would like to submit questions or come to the stands, I agree. So I'm a functional urologist and I deal with male incontinence, and at 3 years I'm surprised it's not longer. It takes that long for patients with incontinence to present. I think ED is dealt with excellently after radical prostate surgery, but incontinence has been forgotten. Your practice is going to change, but how can we make it change nationally so that patients can access these kind of treatments sooner?
I don't know is the honest answer, but I can't explain why it is 3 years. Why should it take 3 years? We know if they're really wet in 6 months, they will be wet for the rest of their lives, if they're really, really wet. The old explanation of they'll get better as 12 and 18 months happen doesn't really apply in certainly the local PROM data that we have in Cardiff, or it doesn't bear, it's not applicable anymore. So I can't explain why it is 3 years. Whether you have very long waiting lists, and maybe the section of reconstruction and oncology, we need to work together to make this better.
It's not a waiting list. I think it's patients are relieved they've been treated for their cancer. They then get offered treatments about their ED, and I think the original BAUS audits concentrated on erectile function, maybe less on incontinence. And I think it's something that's not talked about. So I think it's maybe education rather than necessarily kind of waiting to be referred on. Can I take any questions from the audience? Or if not, we'll look at the app.
So feel free to send us questions via the app. I've just got one question, if that's all right, Krishna. So you presented the POUT data and adjuvant chemotherapy for that group. What's the trial that next needs to be done for upper tract TCC?
What's the
trial that we need to be doing next for upper tract TCC?
Well, it's interesting. I asked this question of Alison Birtle, and in particular I asked her whether there's going to be a role for neoadjuvant chemotherapy in high-risk upper tract TCC, like we know there is in bladder. And I think that there will probably be a role. It's trying to select the right patient group. And her response to that was that they only want high-risk group, and that you can't necessarily say that from imaging. But I think imaging is getting better, and we can generally predict who's likely to have a high grade or a muscle invasive upper tract ECC. But I think there is an opportunity to do that.
So we've seen some discussion in the endo section about the role of biopsy and with the guys subspecialist MDT for upper tract TCC, but the role of a biopsy does give you reassuring data on grade, which may actually then allow you to predict who's going to have high risk disease and who may benefit. So perhaps there is a role for biopsying everybody to pick out that group.
Absolutely.
Okay, thank you very much, Krishna. And I'd like to invite Io to the stage now, and she's going to talk about andrology. And I think the andrology section should be commended for the work they've been doing. The recent consensus guidelines on genitourethral emergencies are excellent, very comprehensive, and have been very insightful for our trainees and my colleagues, and very, very helpful. I think also interesting new innovations in the treatment of coronas that have been going on this year and have been presented at BAUS. But thank you.
Good afternoon, everybody. Thank you for inviting me to give this talk. I'm going to do a very quick run through the highlights so far. I'm going to try and cover as much as I can. So I'm going to look at benign andrology to start with. There was an abstract that I thought was quite curious from the Royal Free Group, where they've designed a website and an app which allows patients to go on the app and identify their sexual dysfunction, and then it provides them with advice. We know that Viagra is now available over the counter, so this is really useful for patients where the app can give them advice to go and actually just buy some Viagra, which actually I'm still seeing a lot of patients in my clinic where they haven't been tried on any PDE5 inhibitor at all. So this is empowering patients potentially and hopefully reducing some of our waiting lists so that we're seeing patients who have had at least first-line treatment before they even go to the GP. And the study identified about 77% of the patients who went on the app had ED. I think 80% actually had premature ejaculation. The other thing that's really useful is this is useful epidemiology data for patients, so that when we see them in clinic, we can say to them, you know, premature ejaculation and ED is common. You're not alone. We know this, but patients don't always identify with this. So I thought it was quite a nice little study that was presented there. There was a retrospective review from the UCL group on hematospermia. This is something that we see not infrequently, and I recall revising for FRCS not too long ago, and it was one of those vague things that there's no real guidelines, there's no real guidance as to what you should do for these patients, and everyone gives you slightly different advice about what you should do. And I think our general impression is that it's not something to worry about as long as they don't have hematuria. But what do you tell these patients? Because they're concerned. And so this was a nice study to, one, tell us the diagnostic yield, because these patients are often worried about prostate cancer. The diagnostic yield for the pickup rate for prostate cancer for this study was 3%. So you can reassure the patients that, you know, the likelihood that you've got any cancer or anything significant is low. If you do feel that this is a patient that you want to do some investigations on, there's really no benefit from doing anything except a truss or a multiparametric MRI. So that's really what you should be doing. They looked at a few other investigative modalities, and the diagnostic yields were very low for those. So those are the only two investigations that are worth doing if you're going to do anything. Male subfertility, there was a great talk from Pippa Sangster from UCL. We know that there's an increasing demand among male cancer patients that they want to have, they want to preserve their fertility, and we need to empower them to enable them to do that. And that means that we identify them early, and we try and cryopreserve them before we touch them with any type of treatment. We know that patients with testicular cancer often will have impaired semen parameters before they've had any treatment. That's surgery, and certainly we should be doing it before they start any chemotherapy. The best time to pick them up is before you do the orchidectomy, and that's still not standardized across the country. Urologists are still sometimes saying, well, we'll do it before they have their chemotherapy. You may have lost the opportunity to save any sperm for these men, and that's not acceptable. So what PIPA's really trying to advocate is we need to, we're not doing too badly with testicular cancer. I know I've just criticised everybody, but we're not doing too badly with testicular cancer when you compare it to the other cancers that are out there. So we need to make links with our hematological colleagues and our oncology colleagues, and that's leukemias, lymphomas, really the colorectal cancers. And while I'm on the topic of colorectal cancer, we really need to be speaking to the colorectal surgeons about inflammatory bowel disease. These are young men who will not have any advice given to them about preserving their fertility. They're going to have lots of surgery, and they're going to have ejaculatory dysfunction. So we need to make those links within our units. Now, there's some very promising results from animal studies where they've used spermatogonia stem cells, and they've had successful live births. So there's really there's a lot that's promising for young men in the future, that we may be able to use stem cells to preserve their fertility and to help them have live births in the future. So that's something to come. I've only got one study in this section, which I think Nick Watkins is going to go into a bit more details. I thought it was a great study, really well planned, really useful, with some very interesting results. So I'm not going to say too much about it. I'm going to skip through that fairly quickly. Now, this is really my baby, and that's penile cancer. We don't have a huge amount of studies in penile cancer. We've only got one international trial, and that's the IMPACT study, which has really struggled to recruit. It's a study that we need, but it's not recruiting. We're not really quite sure why. It's an American-based study which Nick Watkins is lead for in the UK and in Europe. But that's something that I think we need a UK study, and we certainly need a European study, and we certainly need to try and get IMPACT off the ground in some way. This was an interesting study from the Christie, where they looked at PIN and LS status with regards to P16, which is a surrogate marker for HPV status. With retrospective study over 10 years, they found that patients with lichen sclerosus were much more likely to recur with their PIN much more quickly than those who did not have LS, and patients responded better if they had either imicramod or imicramod with surgery. Now, what was really interesting is 13.6% of these patients are still going to progress to invasive cancer, regardless of what their P16 status is. And this is a dilemma, because when do you discharge these patients? I'm often asked from my colleagues in the West Midlands, do you want to see these patients? My answer is always yes. I follow them up. But when should I stop following them up? And I don't think that's something that we've defined. When you look at P16, it's a strange marker, because when this group looked at progression, there was a slightly better progression rate if they did not have if they were P16 than if they were not. Whereas PIN disease-specific survival was certainly better if they were P16 positive. So I think this is an area we still need to do a bit more work on in terms of PIN and how important this is and how we ought to be following these patients up. This was a nice study from I think predominantly Nick Watkins' group, but it was a retrospective study, two super-regional penile cancer centres, Leeds, George's, Marsden and Brighton. They looked at patients over between 2003 and 2017, so a good period of time, and they looked at patients who had N3 status disease. These are patients with very poor prognosis. They do not do well, and we're really looking for the best way to treat them. There was a meta-analysis late last year, which came out looking at the role of radiotherapy for high-risk pelvic nodes. And traditionally what the EAU guidelines recommended was that patients who have suspicious pelvic nodes or high-risk potential pelvic disease, so these are patients with 2 or more nodes positive from their groin node dissection, or they've got extracapsular disease. What do you do about their pelvis? And the EAU guidelines were always of the mind that we ought to be giving these patients the option of either radiotherapy or surgery to remove these nodes or treat the nodes. Now, based on the meta-analysis, the guidelines have changed last year, and they're now recommending that we ought to just give them surgery, that there's no role for radiotherapy. This is still controversial because a lot of the studies that guidelines were based on are old radiotherapy studies. So I really think this is an area that we need modern data on, and I'd urge all my colleagues in penile cancer to please let us work together so that we can actually find the answers. But back to this study for N3 disease, which is a different disease in its entirety. 82% of patients were able to complete treatment. Of that proportion, only 43% relapsed. 50% relapsed within the area that was irradiated. Now, the median survival is not great. We're not like prostate cancer and some of the other cancers in urology. Cancer-specific survival, 4 months. Recurrence-free survival, 35 months, and overall survival, 39 months. So this is a group that do badly, and we need better treatment modalities. Now, when they looked at the radiotherapy versus the non-radiotherapy groups, the patients who had radiotherapy did slightly better across all 3 areas, so overall survival, recurrence-free survival, and cancer-specific survival at 5 years. Not a lot of patients are getting to 5 years who have N3 penile cancer. So this is another nice study from the Christie where they've looked at Centipen as an alternative to classical DSNB, which most of us use in penile cancer. Now, the Centipen does not use nuclear medicine. It uses magnetic technology. You can inject the isotope up to 7 days before you're planning to do your procedure, as opposed to DSNB, where it's usually the day before or on the day. So it gives you much more flexibility. They also suggest that there's a reduced cost associated with it. So this is a potential area for the future that we can look at. They had very promising results which show that it was just as good as DSNB. So I think this is something that it would be nice to see this rolled out across the country. Again, I think we need to collaborate with the other penile cancer centres. My personal best of BAUS this year, I was very, very pleased to see Rue McDonough get the St. Peter's Medal. He's been my mentor for years, great guy, very well deserved. I saw a talk by Ari Parnham from the Christie, which is another nice talk about updates in penile cancer. I think we all need to think about reconstruction for these penile cancer patients. They're getting younger, unfortunately. They're still presenting late, so we're still having to take off a lot of their penis. And these patients are burdened with psychological distress from this. And phallic reconstruction at UCL or one of the other centres should be part of our management strategy, and we should be talking about it with the patients early. The outcomes from these procedures are excellent, and patients should be offered in much the same way women with breast cancer are offered breast reconstruction. Ari gave another talk about career options in andrology, which was great. It's really nice. I saw it on Twitter. Still an exciting subspecialty option for trainees. We still want them to come and join the specialty. There's still lots of room. There's still lots and lots of work to be done, especially in penile cancer, I would say. And that is me done. Thank you. Any questions? And I look forward to seeing you in Birmingham next year.
Okay, so an exciting time in andrology. I think the thoughts of cryopreservation before radical surgery for testis cancer is really important, isn't it? You've brought up the fact that we need to be involving other allied specialties, so colorectal, hematological colleagues that are involved in leukemia, lymphoma. How do you think we could go about that?
That's a difficult question. I think we have to go and talk to them because these are things that are not on their radar, but they know that. I think when I was in London, I went and spoke to colorectal surgeons and they said, great, we know that this is something we need to do, we just don't know how to go about it. So I think going to their MDT as a start, I think we just need to be more involved. I think they will bite our hands off. Yeah, and that's something that we have to do.
Education and collaboration coming to the testis MDT. So I do apologise, the questions coming up on the app are a little bit delayed, but we do have one now.
So we've had a great question through on the app. So should BAUS get involved in the campaign for male HPV vaccination with regards to penile cancer?
Absolutely. The government last year has actually said that boys will be allowed to have the vaccine. So I don't think we need to get involved anymore. But if they hadn't moved on that, then absolutely. I never really understood why you would just give it to boys, and we're hoping that we'll see a similar decline in the prevalence of penile cancer that we've seen in cervical cancer. But it's going to take some time, obviously, because unlike other cancers, penile cancer is going up.
Okay, thank you very much. If there's nobody else, that's it. Thank you.